want to welcome you all here as friends of Madeline. And also as friends of the chemistry department, you are welcome to come to our picnic, which is May 23rd at 4:30. That's a Wednesday. If you are interested, you need to sign up outside of the stockroom, which is just one floor down and next to the elevator. You can see the sign up sheet down there, and we'd love to have you. Also, since this is only the 8th of 18, we're going to hit the halfway mark tomorrow at 4 o'clock here in this room, where Wyatt Smith will be presenting them off. So you are also invited to that. And one last thing, I keep always forgetting this. Madeline's talk, as all of the talks, will be in perpetuity up on YouTube. So that if you want to see it multiple more times, or you want to binge watch chemistry senior experiences from the last 5 years, there's 73, soon to be 74 up on the web. So this is, you can put that in there with your Game of Thrones and your Stranger Things. You can binge watch chemistry. Just put it out there. But if you search YouTube Senior Experience Chemistry in Lawrence, it'll take you to those talks where you can binge watch after school's out. It's with great pleasure that I introduce Madeline. It's one of the rare double degree students that has hung in there in the sciences to do this. And I know what a tremendous amount of work it is to plan to make this all come together, because chemistry has such kind of a rigid set of requirements. So it's always very admirable to have her smiling face in class. And I get to see her the rest of the term, actually. This is going to be awesome as well. Hailing from Montana, she's now officially burnt out. Sorry, not officially burnt out. Scratch that. It's just going to take some time off, go back to Montana, do EMT work, and prepare to apply to medical school, or get a master's in clarinet. Which is very Lawrence awesome. So without further ado, I'll give you.
Thank you. So today, as you can see, we're talking about HIV. So thank you all for joining me to talk about HIV. We're going to start by talking about how HIV originated and where it came from. And it started in 1920, and there are actually two different types of HIV, HIV-1 and HIV-2. But HIV-1 is the most prevalent kind, and that's what we'll be referring to most of today. So when I say HIV, pretend there's an HIV-1 at the end of it. How it started was there was a cross-species transmission event with chimpanzees and humans. So it's via this hunter theory. So humans were going out and killing chimpanzees, and they would get some of the chimpanzee blood in their own bloodstream sometimes from cuts on their skin or other things similar to that. And how this worked is the chimpanzees have this virus called the simian immunodeficiency virus. And the chimpanzee virus would go into the humans, and a lot of times it would just go through and nothing would happen, and the humans would be totally fine. But sometimes it would morph and change into HIV, the human immunodeficiency virus. So that's where it started, and this happened in the Democratic Republic of Congo, Kinshasa, which is there on the map. And so that happened in around 1920, and we can trace it to there because there was the most genetic diversity in the strains of HIV. So HIV has a lot of mistakes in it, which makes it's called a quasi-species, because every time it replicates, it kind of turns into a new form of HIV that still acts the same way. But the most strains were found in this area in the Democratic Republic of the Congo. And it also follows with, there were some really big infrastructure routes through there at the time, which corresponded with the sex trade and through immigration. So as I said, this is a fast replicating virus, and it started with chimpanzees going to humans. So how did we get this, how did we figure out what HIV was and where did it come from? In the 1980s, HIV was first widely recognized in the US. And then eventually they came to find it in other places. But everybody was starting this trend among gay people, and they were seeing that there were these rare diseases being found among gay men in big cities in New York and California. And these diseases included Kaposi sarcoma, which is a rare cancer, and pneumocystis pneumonia, which is fluid buildup in the lungs. And the people who are most susceptible to these are people with immune deficiencies, like HIV. But they were really only finding these among gay people gay men in New York and California. So everybody was like, well, it must be related to being gay then. So they called it GRID, which was gay-related immune deficiency syndrome. So they assumed that the people who could get it were gay, and that was the way to get it. But people did research, because that's what you do. And in 1983, HIV was isolated in France and the USA National Cancer Institute. So in 2 different places in the world, but they came together and came up with the title of HIV/AIDS, human immunodeficiency virus and autoimmune deficiency syndrome. So in 1983, the CDC comes along and is like, well, now we're going to identify who's most at risk for getting HIV, which eventually turns into AIDS, as most of you guys probably know. And the first was homosexuals. So we kind of talked about this a little bit earlier. Gay people were most at risk, and in the United States, that's still true. Gay men are still the people with the most HIV in their systems, but in the whole world, there's actually more women who have HIV. And the reason that homosexuals were targeted for this is because of anal sex, and that's one of the biggest ways to get HIV because of seminal fluids and blood. So the next of this 4-H club that the CDC talked about was hemophiliacs. And this is because hemophiliacs need a lot of blood transfusions. So at the time, they weren't really testing blood much. They were like, everybody's blood's probably clean. Let's just throw it in some new bodies. And that didn't go well. So hemophiliacs were pretty at risk for HIV because of this. But now we have some really good things in place that test blood before it gets put into the body. The third one are heroin addicts. And so I think they were trying to stick with the 3 H's, but what they really mean is anything, any kind of drug that you shoot up. And this is because if you think about it, a needle goes straight into your bloodstream, and if there's HIV in that needle, it goes into you and you get HIV. And fun fact, I guess it's fun, is that HIV can live in a needle for up to 42 days after being used. So keep that in mind. And the fourth one was Haitians. And this is because in the 1960s, people were starting to see this disease progress in Haiti, and they weren't tracing it all the way back to the Democratic Republic of the Congo. So everybody was like, oh, it's all the Haitians' fault for starting this, which is, we know, totally false, and just like a cause of very big stigma around this disease. So why do we care about this, and what are some statistics? How many people have this? So this blue circle here is the whole population of the entire world. And this purple strip, that you can probably see right there, is showing the population living with HIV/AIDS. And the fact that we can see it on that giant circle of the world proves that it's a big problem. And an interesting fact is that if this purple is the population living with HIV/AIDS, imagine that's a piece of pie. So if you were going to eat this green sliced piece of pie, that's a pretty hefty piece of pie, right? So that's 1 out of 7 people who have HIV/AIDS but don't know it. So it's always good to get tested, and if you think you're at risk, be tested, or if you know a friend who is, do that too. So we're going to go into how HIV works, and then eventually how we can make some drugs that goes into stopping HIV. So there's some various components of HIV, and this is called a virion. This whole thing is a virion. It's basically a cell that contains the HIV components. So to start off, we have our outer envelope, which contains everything. It's kind of just in charge of keeping it all together so that HIV can be transmitted. And we have glycoproteins on the surface of the outer envelope, which we'll use later for the fusion into a new host cell. And we have capsid, which is on the inside of the outer envelope, as we can see, and that kind of holds the RNA that is in charge of the HIV transmission. And that's the RNA right there. And these are reverse transcriptase, which are attached to each of the RNAs, and those will help get replication started with HIV. And then we have 2 proteins. An integrase is the first protein, and that one will be in charge of getting it into our chromosomes in our body. And protease is what helps make a new active virion once we get all the way to the end of replication. So we kind of have like an outline, and you know what the cell looks like. We're going to see now how the HIV actually gets into a host immune cell. So if this is our HIV cell, or HIV virion up here, and we have our CD4 host cell. It's just an immune cell. It's called CD4+, with respect to HIV. And what happens is that there are these glycoproteins that I talked about a little bit earlier on the surface of HIV. And then we have cell surface receptors, which are on the surface of the host cell. And those kind of come together and they associate, and it causes this change in how the host cell and the virion interact, which makes the host cell break open and allow for the capsid to be placed into the host cell. So now HIV is starting to run around in your system, but it can't do that until the capsid protein gets digested. So we have the capsid, which is the beautiful purple thing here, and it gets digested, which means that all of the capsid goes away except for the RNA and the proteins that go with it. And so after those have been digested, the RNA is free to roam around and get transcribed. So we have our blue thing that was RNA transcriptase, and that will convert this viral RNA, so what we saw in the little red strips, that will be converted using reverse transcriptase, and it's going to bring in some host nucleotides from the cell. So a lot of you probably learned about your A's, C's, T's, and G's when you were in a little bio class, even if that was 4th grade. Most people have heard about it. It's the components of DNA. So those are coming from the host cell, and they're going to come in and match up with the next nucleotide on the viral RNA. And that'll eventually, the viral RNA will go away, and there will be a completed single strand of DNA. And this process then repeats, again, with DNA polymerase instead, and we get our double helix of DNA, which many of you probably know what it looks like. So it's this beautiful blue picture over here, and we have a DNA strand of viral DNA. And then, this is the part that really is the kicker to get it into your system. So here we have integrase, which is one of those proteins that came in with the virus, and it's yellow, in the yellow there, and it's going into that green strand and cutting it. And how that works is it goes in, and the green strand is your chromosome, so that's your DNA that's always in your body. And it's inserting the viral DNA, which is purple, into your system, which is what causes lifelong infection. So that's why people with HIV, we have such a problem, such a hard time finding research to actually cure it, is because it's actually being put directly into your body's chromosome. So once it's in the chromosome, we get RNA polymerase, which is part of the host cell, and it comes in and it makes this mRNA, which will eventually make some proteins. But that mRNA is made, you can see the little reddish orangish strand coming off there, and that'll go out of the nucleus. So once that mRNA is out of the nucleus, it uses a ribosome, which is this little blue thing here, to make new proteins. And these proteins then go up to the cell surface, and once this mRNA strand keeps getting sent out, it will make more proteins, and eventually there will be a lot of proteins on the cell surface. So you can see that there are a lot of proteins there hooked onto the cell surface, and that's what signals the host cell to make a new virion. So it kind of blubs back out and makes a new inactive virion. So those proteins are still not actively working, but they're able to trigger the formation of a new virion. And finally, the new virion becomes infectious by protease. So we have our strand of proteins, our green protein, our pink protein, purple, and blue, and these are called GAG-Pol polyproteins, but we'll call them green, pink, purple, and blue for now. And protease comes in and it just cuts each of these individually, and we end up with separate proteins that are now active and can form the mature structures that make up our infectious virion, which then can go up and infect other cells through the process that we just saw. So what our job as scientists is to come up with drugs that can stop various processes that go through HIV replication. So the first one is fusion inhibitors. So at the beginning we talked about how the glycoproteins and the cell surface receptors associate and then break open to allow the capsid to go into the cell. So one of these is fusion inhibitors, and there's 3 main types of fusion inhibitors. The first are these drugs that can bind to HR1, which is just this complex here with the CD4 cell membrane that's just first associating with the glycoproteins on the HIV membrane. So right about there. And the drugs go in and basically just stop it from being able to continue to associate and break through. The next one is HR2. So after the glycoproteins and the cell surface receptors have been close together for a longer amount of time, the drug can go in and stop that from happening. And the third one is that when we get to this stage over here and it's about to break through the cell and allow the capsid to go in, the drugs come in and just kind of hold this formation together so that it's not allowed to break open the cell. So those are fusion inhibitors. And the next one are nucleoside reverse transcriptase inhibitors. So we talked about that reverse transcriptase, which was in charge of making the DNA that gets it into your chromosome. And how this works is that there's actually an inhibitor that goes where the nucleotides should be going in and just kind of stops it. It's like a stop sign in the middle of the road. Actually, it's kind of like you're driving your car and a cow walks in front of your car. And so you're like, well, now I can't drive anywhere because the cow is there. So that's what this is there's just a cow in the middle of the road and you can't move, which stops transcription and we are no longer able to make viral DNA. And the next one are these non-nucleoside reverse transcriptase inhibitors, which means that instead of it being a cow in the middle of the road, it's more like a stop sign on the side of the road. So it stops your car because you know you're supposed to stop. But it's not quite in that active site. It's not the cow in front of the middle of the road. It's on the side, but it's changing the way you're allowed to drive. So it changes this shape of this area so the nucleotides can't come in. So those are non-nucleoside reverse transcriptase inhibitors. And the next one are integrase inhibitors. So we remember our integrase. This is one of my favorite videos. It's very cool. It's getting it into your chromosome, which is not cool. And then we have, so our little integrase protein, this little yellow thing, would actually be completely stopped. The drug would go right in its active site, so it would not be able to open and close and cut that chromosome strand, that DNA strand in our body. And there are many drugs out there that are integrase related. And the next one that we're going to talk about are protease inhibitors. So that final step in the process of making our active virion is done with protease. So protease this is a beautiful picture of the protein and what it kind of would actually look like as a sheet model. So this yellow thing is protease, and then if you see in the middle here, that is a little blue drug, and so that's right in the active site of protease, so it's not able to open and close to cut each of the proteins. So all these drugs are really great, but what about drug resistance? Because HIV is such a rapidly changing drug that there's a lot of drug resistance. And the reason for this is that reverse transcriptase causes a lot of errors. So when you're making your DNA strand, as we've seen this picture before, the DNA strand's being made, but there's a mistake in this one. So you know your A's and T's are supposed to match up, so in this case green and red and purple and blue are supposed to go together. And we have our red one here that is actually supposed to be purple because it's going to match up with that blue one. So now there's a mistake that's been made. And a fun fact is that for human transcription, there's usually about 1 to every 10 to the 9th, which I believe is about a billion. 1 in every billion transcriptions, so each one of these little things, 1 in a billion of those, there's a mistake. But in HIV, it's 1 in every 1,000. So there are a lot of mistakes being made in HIV, which allows it to become drug resistant. It's able to have this high virus production turnover, so it can kind of morph to how the drugs are acting with it. But we came up, well, I did not personally come up with this, but there's a really cool thing out there called HAART, Highly Active Antiretroviral Drug Therapy. And this is basically a combination of at least 3 drugs from these approved drug classes. So we have our fusion inhibitors, our NNRTIs, our NRTIs, protease inhibitors, and integrase inhibitors. So what they do is they pick 3 of those that work best for your body, and they give them to you so that you take your set amount of pills each day, and those 3 are able to work in your body and get HIV down to a very, very low level in your body. And the reason this works is because HIV is probably not going to be able to get a mutation for every protein in order to escape every single one of these drugs. And if one starts to have a lot of drug resistance, they can just switch it out for another drug, since we have so many options now. In fact, when we first started getting HIV drug therapy back in I believe it was like early 1990s, late 1980s, there was only one drug on the market, and it was called AZT, which some of you have probably heard of. But it was the only one, and so they were seeing a lot of problems with drug resistance because it was the only drug out there, which is awesome that now we have all these other drugs. And HART showed a lot of improvement over 3 months with about 70 AIDS inpatients. So they had an increase in their CD4 count. So those immune cells that we talked about earlier that HIV is going in and infecting, they were increased, so there was not as much HIV in them, which is awesome. And there was a decrease in viral load levels, so there was a lot less HIV in the body. And there was an increase in body weight and some increases in parts of your blood. So the HART was shown to be very effective, and in 2006 they showed it was helpful again and again in 2008, and any complications that were found were just because of the drugs themselves and the side effects you'd expect from having those. So obviously HART is great, but we still need to be coming up with more drugs because of drug resistance. And there is a new development in drug production for HIV. And this is to target this capsid. So this is a much more pretty drawing of the capsid than what I'd had earlier. And you can see that there are these groups of 6. So this is called a hexamer. And it's just a protein that is held tightly together in these groups of about 7 more. So they're just kind of like being, the paper I read actually described it as a molecular level knitting project. So they're so closely tied together that it's very hard for them to become unraveled. And unlike a knitting project, there's no end that you can like clip and the whole thing unravels. This is like held so tightly together, which makes it act as a very good shield for the virus, which is why it would be good for target development, because if you can unshield the virus, you can do more with that. And the capsid is actually the most consistent part of the viral genome. So we were just talking about all of the problems that can happen in replication, and that there can be a lot of mutations, but that rarely happens in the proteins that encode for the capsid. There's about 70% genetic conservation across all of the forms of HIV. So the capsid is a very good thing for drug development. So researchers started with epsilon, which is this small molecule that inhibited capsid activity. And what it does is that it blocks a single protein on the capsid. So if we look back, I'm just going to scroll back here, if we look back at this, it would just be kind of sitting in the middle of one of these proteins here. And it would only be effective, they found that it was only effective in post-entry events. So so once the capsid is actually in the new host cell. It wasn't effective while it was being developed during the new virion cycle. And they found epsilon had no effects after the capsid had been digested, which kind of makes sense because it's targeting the capsid, and if there's no capsid, how do you target the capsid? But this ended up not being tested on humans because it was very not specific. Epsilon is also used for, I believe, like a hearing disorder, a couple other things. So they didn't want to test it on humans because if they were focusing on the capsid, but epsilon was having all these other effects over here, it could cause a lot of problems in the human body. So they decided that it was no longer, it was not a helpful drug. But that led to a lot more research being done on the capsid. And this new one is a compound that works on more parts of the capsid rather than just as a single molecule. And this compound wedges between adjacent capsid proteins. So we have our green capsid protein this time, and this little green thing here, the lighter green, is this new molecule, which is called GSCA1. And it actually stops replication at 2 stages in the life cycle of HIV. And the first is assembly. So it stops the capsid from being able to properly assemble by just like speeding up the construction process. So imagine if you were trying to knit really fast, but you were not very good at knitting, and so it just kind of turned into this really ugly scarf. And then the capsid would be kind of useless, and RNA would be able to not be able to be put into the new host cell very well. And the other way is with disassembly. So after the capsid is inside of the host cell, this new molecule is actually able to come in and interfere with disassembly. So it kind of holds it tight together. You can see that it's pretty well wedged in there, and it's like holding it together. And so the capsid's like, I want to break apart, I want to break apart. And the molecule is like, sorry, you can't do that. We're just going to hold you together, which means that the RNA can't be released and it can't be replicated, and we don't get as much HIV. So one of the fun things about this molecule is that it might have a longer effect on the body. And that's because it's the solubility of a rock. So most people who take HIV drugs take them orally, and they dissolve in the body and go through the metabolism process. But this has a very low solubility, so they would have to do injections. And this is maybe a good thing, because currently it's active for about 10 weeks, and so they're hoping to push that to 3 months so that people with HIV don't have to come in, don't have to be constantly on a regimen of drugs daily, or less of those drugs, because they just come in every 3 months for an injection, which would be awesome. And the reason I'm kind of talking about this hypothetically is that this trial actually starts in humans this year. So it's very exciting that there's actually finally a new drug coming out for HIV and being tested on people. The last time a drug was actually tested for HIV was 10 years ago with the integrase inhibitor. So it takes a long time for this drug development. The drugs do have a high success rate though, but they're often inaccessible. So there are many reasons for this, and the first one is the cost. It's very expensive. In fact, when AZT was first discovered, the drug we talked about a little bit earlier, it was, in today's currency, about $17,000 a year in order to get AZT. So not everybody had access to it because it was very expensive. Another reason that people have inaccessibility to drugs is that sometimes they get the wrong drugs, and people give them counterfeit drugs, or people will try to come up with these counterfeit drugs that act the same way as HIV therapy, but they're cheaper. So the people making them get a profit, but the people taking them are not getting the right drugs for what they need. And the third reason is that there's often an inaccessibility to hospitals and clinics and places where people can get the drugs and other medical care. And the third one is that there's a lot of governmental influence and interruption in providing medical care to people. And this goes for HIV antiretroviral drug therapy and a lot of other things as well. And the final one is that there are a lot of poorly done humanitarian aid organizations out there. And I'm going to talk about that a little bit more now. So there's some problems with humanitarian aid, which is one of the ways that people actually get access to antiretroviral drug therapy. So it's important to know what the problems are with humanitarian aid in order to improve our access to HIV antiretroviral drug therapy. So the first problem is competition. So in emergency aid, there's like this huge surplus of organizations sometimes that are going in and they like fight for their spot to help people, which can cause a lot of hurt actually in the area. And this occurs between governments and between NGOs and governments and all the arrays of types of humanitarian aid organizations. And the next reason is that there is this neutrality failure and a governmental influence. So sometimes it's actually difficult and unethical to remain neutral in certain situations. So in the Rwandan genocide, humanitarian aid organizations would go in and they would have to choose between feeding the killers or going under as a humanitarian aid organization. So they usually chose, well, let's feed the killers because then we'll still be supported as an aid organization. So they would help the Hutu, who were killing the Tutsi and the Twa, and then the people would be able to go back out and continue hurting people. So it's like this process of, are you actually helping or are you hurting? And another reason that the governmental influence is important, well, it's actually a problem in humanitarian aid, is it actually is used often as a way to show power to the countries that are helping. So sometimes the humanitarians from governments and stuff go in and they're like, I'm helping, but they have to contribute to the war in order to help. So they'll go to warlords and be like, I'd like to help your people, and give them lots of money, which keeps the war going longer, but they're still helping people. So they're helping but also hurting at the same time. So sometimes they outweigh the costs and cost-benefit analysis and all that stuff, but that is one of the problems. And then one of the other things is to talk about government humanitarian aid organizations, and I'm just specifically going to talk about the Peace Corps, which everybody is like very gung-ho about the Peace Corps, but I feel like it's really important to know that there are some problems with this organization. Due to its governmental connection, it's not solely focused on the needs of humans at home and abroad. It's more based on this like international promotion of our government. And it operates on inertia rather than change, so it goes in and is like, let's keep doing the same project even though it's not helping. And they have an organization within the Peace Corps that goes and covers up the problems that the Peace Corps is making. So it'll go in and the Peace Corps is like, oh no, we made a mistake in this area, and it's not going well, but we'd like to continue the project so we can continue like having an international relationship with these people through a governmental perspective. And so there's this organization that comes in and kind of like weaves things out with the people who work there or who live there, and with the government to make sure that nobody ever knows that there was a problem. And one of the other problems with the Peace Corps is that they don't actually interact with the people, well, obviously they interact with people in the communities. They're not always asking exactly what the people need or want or what's best for their community. And they don't always do a great job of evaluating their impact. As I said earlier, there's that organization that comes in and kind of like pretends like everything's fine. But as long as Peace Corps is in countries and people are still contributing to it, the US government's going to still be promoting it and making sure that it's out there for political stance. Another reason that there's a problem with the humanitarian aid are these ideas of my own NGOs. So people go in and they're, well, anywhere, and they kind of are formed by whoever feels like it. So you're like, oh, I want to make a difference. Okay, so let's make some money and then just like send it over to people. And this goes for money or t-shirts or whatever. And a lot of times the people in the communities don't actually need this. So they go in and they have like very little ethics because they don't know as much about it. They just want to help people, and it actually ends up hurting way more than it's helping. And so overall, these like Mongos have are very poor organization. They have a lack of resources and a lack of experience. And I'm not saying that's every time there's a Mongo made. I'm sure there's some very good ones out there, but most of the ones that I came across in my research were way more ineffective than they should have been. And actually, some bigger organizations will promote the Mongos because then people will feel like they're helping. And when their Mongo goes under, they'll contribute more to the bigger organizations. So think about that when you're donating to things. And the final reason is that humanitarian aid is often a short-term solution to a long-term problem. So you get a Band-Aid and you put it on, and it doesn't really do much because you're kind of bleeding out. And then you put another Band-Aid on because you're like, ooh, that'll help more. And it ends up not ever doing anything of importance. And there are some organizations that are good at making sure they stay in the area, and I'll talk about those in a little bit. So what are some ways that we can help to eliminate the prevalence of HIV and to improve our ways to help other people with other diseases and health across the country? First one is pretty obvious. Education and prevention is one of the biggest ways to go. There's actually a program in Rwanda called HDI, which is Health Development Initiative, and there are a few GlobeMed people in the room who know what I'm talking about. But we worked on this program with them that is now fully funded and is working really well, called SHARE, Sexual Health and Reproductive Education. And what they do is go into schools and talk to students and really inform them about how HIV is transmitted and how it works, so that students are more likely to use condoms and prevent sex, or prevent getting HIV. Other way around. And that's something that we can do even here, as I'm doing kind of today, is educating you about HIV. And you can do this anywhere, as long as the conversation permits it. So another way that we can help eliminate the prevalence of HIV is to reduce the expense. And I'm not really sure how to do this. I'm not an economics major. Obviously, this is a chemistry senior experience, so I've been able to talk about humanitarian aid organizations, but I don't know anything about economics. But I think it would be great if we could reduce the expense, maybe providing universal health care to everyone. And I know that's a controversial topic, but I think it's important to provide everyone health care if they need it, and whenever they need it, and wherever they live in the world. And the final would be to improve our humanitarian aid and NGOs. So as we know, not everybody does have universal health care, so what can we do to help with that? And everybody always wants to help. So make sure you're helping using good organizations. PIH is a good example of a good humanitarian aid organization. They will go into a country that's struggling or an area, even in the United States, there's many programs here. They go in, they talk to the community, they figure out what the community wants, and then they implement programs and let the community be part of those programs and become trained in a lot of the medical things that they can do. And if you want to get involved on campus, GlobeMed is kind of a model based on Partners in Health. So we do a lot of making sure that we're helping the community that we're going to. So anyway, I've ranted about humanitarian aid organizations for a little while. I'm just going to give a quick conclusion to my whole talk, and we're going to go back to the beginning. Remember where HIV came from? Was from chimpanzees with this hunter theory. And we know that HIV is a very fast mutating, or a fast replicating virus. And so we came up with some drugs to try to help that. And sometimes these drugs don't work because of drug resistance. And there are some ways that we can help to improve this, and one of these is creating better drugs that will have less drug resistance with the capsid development, and improving our aid to other communities. So just to end, I would like to thank all these people up here, and I'm sure there are many more that I missed. I'm terrible at acknowledgement pages, but I'd like to thank Dr. Dave Hall, Dr. Stefan Deverd, Graham Sazama, Deanna Donahue, Bart DeSazio. He helped me with a lot of the humanitarian aid organization stuff a few years back. And everyone else, my friends, my core kids, my studio, all that stuff. So thank you all for everything. Oh, and P.S. If you feel you might be at risk or you know someone who is, there's free HIV testing on campus on that date. Thank you. Does anybody have questions?
Questions?
It's like half my citations. Yeah.
So I guess I just want like a further comment, because you kind of talked a lot about what the job is as scientists. How do you, I think also then you talked a little bit about the 4-H's and that those have some biases associated with it, some cultural problems associated with it. How do you think that those interacted at the start of how we started our job as scientists, and how you comment on how that maybe impacted development?
I think there was a lot of testing that was, thank you for coming. I think there was a lot of testing that was done solely on people who were gay or that were part of the 4-H club, and I think it would have been good to get out there and make sure that there weren't other people struggling with this illness, and kind of there was a lot of stigma surrounding the people who were most at risk for it, where there are actually many other people who are at risk that people weren't looking at. I don't know, did that answer your question?
I was asking for a further comment, so there was no real question.
Okay.
Other question?
Yeah.
For the clinical trial that's about to start, did they give any sort of focus on currently infected or sort of pre-exposure prophylaxis trial, or what kind of trial?
Yeah, they'll be working on people who already have the HIV, the virus. For those of you who don't know, prophylaxis PrEP is what it's called, and people can be taking it if they're at risk for HIV. But they're going to be focusing more on people who already have the virus.
For those of us who aren't like myself, complete experts, I know that HIV can turn into AIDS. I don't know if it's easy enough to briefly explain the mechanism on that, and then are some of these drugs, are they going to be more effective when it's like in the HIV stage and before it gets to the AIDS stage?
Yeah, so I think the drugs are effective for both stages, but they are more effective the earlier you take them. And so that was your second question. First question was, how it gets there.
Yeah.
Eventually, if I'm not mistaken, it just keeps replicating and replicating until it gets to a point that the virus is so far progressed that now it's AIDS, because you have such a deficiency. Yeah.
I'm just kind of wondering, maybe perhaps why the HIV virus seems to have a much higher error in when it's doing.
It's very smart. So it knows that people don't want it. Obviously, it doesn't have a brain, but it's a very smart virus. So it replicates, and partially because reverse transcriptase is not very good at its job, and so it just like keeps, when it replicates, it just makes these mistakes no matter what, because reverse transcriptase is not very good. So that's like its brain, kind of, I guess, if you want to think about it.
Will the patients who on this clinical trial be taking just the new medication, and will that put them in danger of higher, faster progression of HIV?
Yeah, so they didn't actually touch on that in the paper that I read, but I think most of the time they do it in combination with another drug to make sure that they're not going to be.
And how do they account
Hurt.
for its success? How does that even?
Because in order for the drugs to work, in order to stop some drug resistance, you have to take a combination of them. Otherwise, as we said, like AZT didn't work as well because it wasn't as in a combination. So I believe they will know if it's working if there is no progression of the HIV virus, or of HIV,
Okay.
I think. But the paper didn't quite get into detail.
Do you mind if I
Yeah.
ask one? I don't remember the technical name for it, the really tightly knitted thing that was like less likely to not.
Capsid.
Yeah, it was like 70%, didn't change. Is there, if there were a drug that did target that, how do they know necessarily that it won't start changing more once there's like a drug targeting it?
Yeah, so they did a lot of in vitro assays beforehand. So that means that they did it outside of the body to start with. And they've done a ton of testing before they can even be starting to approve on human trials. And if it does start to have a bigger effect, they'll probably stop the trial. So, yeah, and people sign a thing that says they're okay with being tested on, obviously. Yeah. Yeah.
Every once in a while we hear about an AIDS vaccine. Is that even a thing? Is that even a possibility, the way you described the way HIV/AIDS works?
I mean, it would be really awesome in the future to have that. I don't think there's anything else out there right now that really works for that. But, I mean, I think in the future they are looking for a cure for HIV/AIDS, whether that be a vaccine or some other mechanism for that, so that people don't have the disease, or the virus.
Why is there such a low variation in the capsid?
Because it's like one of the most important things for making sure the RNA is intact. So I think the virus is smart enough to know that they need to make sure that their RNA stays there with its attached to its reverse transcriptase, and the way to do that is to hold it together with the capsid. And then it gets it into the cell and safely in the cell before it is able to release. So, yeah.
What's the mechanism for capsid digestion? Does the virus do that
It
itself?
kind of just like dissolves I think it just kind of gets into it, and then there's like probably proteins that interact that kind of pull the capsid apart. So.
All very good questions. More? Okay. Well, let's thank our speaker again.